Our first speaker today, who will be joining us via Zoom, is Dr. David Systrom. Dr. Systrom is one of the amazing faculty members of the Pulmonary and Critical Care Department at Brigham and Women's Hospital. He is also an assistant professor of medicine at Harvard Medical School, where he directs the Dyspnea Clinic and the Advanced Cardiopulmonary Exercise Testing Program. Dr. Systrom has been part of the Harvard family for over 35 years, and during this time, he has received funding from various organizations like the NIH, AHA, Department of Defense, Dysautonomia International, and OMF to study different forms of exercise intolerance. For the last 5 years, Dr. Systrom has been using invasive cardiopulmonary exercise testing to investigate the underlying mechanisms causing fatigue, shortness of breath, and orthostatic intolerance in ME/CFS. His recent research suggests that there are commonalities between the two conditions, particularly in neurovascular dysregulation and related hyperventilation during exercise. Dr. Systrom is currently leading an ongoing $8 million study of limb skeletal muscle mitochondrial dysfunction. And this is great news for ME/CFS. Dr. Systrom is a true champion in the medical field, and we're excited to have him via Zoom today. Thank you.
So what I would like to do is, over about 30 minutes, tell you some of what we've been doing at the Brigham and Women's Hospital in this area of ME/CFS and Long COVID, and I'll begin with a little bit of a table of contents here. I'm going to start with a bit of a history, just for your entertainment value, but then quickly move on to our major tool in investigating these disorders, which is the invasive cardiopulmonary exercise test. I'll describe that in some detail. I'll give you a case study, a real live case study of a patient with ME/CFS. I will describe in sequence some of the systemic vascular abnormalities that we have found to be prevalent in ME and Long COVID, one called preload failure, and another which appears to be predominantly a vascular phenomenon on the arterial side during exercise, and that's left to right shunting, and its relationship to small fiber autonomic neuropathy, something I know this group knows a lot about in the setting of Gulf War illness. As a card-carrying pulmonologist, I will step back for a second and tell you a little bit about dyspnea, which I know Nancy mentioned in her, this is shortness of breath or breathlessness. Nancy mentioned it in her introduction. I'll give you a little bit at the end on treatment here, potential treatment. So there was a place, an interesting place at Harvard back in the day. Was established in 1927 by David Bruce Dill, who was a nephrologist at Mass General. He teamed up with the dean of the medical school and the dean of the business school, interestingly, and created an exercise lab in the basement of the business school in this place, Morgan Hall. I went and visited it a while back, and unfortunately, all this good stuff is gone. They put many of the basic tenets of exercise physiology on the map back in the 20s, the 30s, and into the 40s. And for this group today, I'll mention in the 40s, they focused on making soldiers more fit for combat. And then funding dried up apparently in 1947. But it was an amazing place, and many of the basic things that I'm going to tell you about were established here and remain true to this day. So here's what we're doing these days. This is in the basement of the Brigham and Women's Hospital. And we have a gentleman who agreed to be filmed here. I'll point out some highlights here. Many of you may know about the non-invasive version of the cardiopulmonary exercise test. That's here. It's a pneumotachograph and measurements of pulmonary gas exchange. What's special about the invasive variety is the two catheters placed. One you can see in his left wrist, that's a radial artery catheter, and then a second in the right internal jugular vein, that's a pulmonary artery catheter. And as it turns out, this is really where the money is. The catheters tell us things about the interior of the exercising individual that simply aren't available with the non-invasive variety. So here's what we end up with. It's a combination of non-invasive variables and then catheter-derived variables. that I'd like to walk you through quickly here. The first is a time-honored assessment of overall aerobic capacity, and that's derived from a VO2 max or a VO2 peak, the maximum oxygen uptake, and it really reflects everything during exercise, including heart and lung function, circulation, autonomic nervous system, and even the mitochondrion. Sorry, trying to get rid of this. All right. So a couple of things we won't be talking a lot about in my talk anyway, but are relevant perhaps to some patients with long COVID who are super sick during the acute illness. For instance, a pulmonary mechanical limit can be derived non-invasively here. That'd be somebody with fibrotic lung disease. The rest of and I won't be talking about those patients today. I'm going to be talking largely about patients who do not have any intrinsic heart or lung disease with ME, CFS, and long COVID. Most of what we see is here. This is the Fick principle, which dictates that the VO2 peak is going to be derived from the cardiac output at peak exercise and the difference between arterial and mixed venous oxygen content. This normally stays about the same during incremental cycling. This goes up about 5-fold normally, and this drops about 3-fold. And then you realize a 15-fold increase above resting values for the VO2. You can see that we can determine if the central pump, the cardiac function, is related to a depressed VO2 peak. We express the cardiac output at peak exercise as a percent predicted and can determine if the pump is the problem. And if we do that, then we can differentiate left versus right heart disease, largely derived from pressures from the pulmonary artery catheter. Again, I'm not going to be talking about these things today. Occasional long COVID patients will have a cardiomyopathy and land here, and very rarely they'll have pulmonary hypertension and land here. What you're going to see along the way here is that all of our patients with ME, CFS, and long COVID, almost all of them land here, and then a subset lands here. And I'll spend some time telling you about this. All right, here's a quick case study. A real live patient I saw just a while back in our dyspnea clinic at the Brigham. She was then a 32-year-old chief resident at Boston Children's Hospital, and she's given me permission to share some of her demographics. She used to be a competitive bicyclist. She was fine until she got the flu. So remember, post-viral syndromes are ubiquitous. Of course, long COVID is a good example of that. Hers was influenza that was documented. And following that, she had progressive deterioration of her ability to exercise and even make rounds at Children's Hospital. She had profound orthostatic intolerance and new one flight of stairs dyspnea on exertion. She had about $1 million spent on her by cardiology, largely, all negative, and came to us distraught. She was so bad, her program director actually let her go, accused her of malingering, and I know this will resonate with many in the audience. What we determined was that her VO2 peak was about 3/4 normal. There was actually a non-invasive test before this where this was 50%. And when she was in her prime, I'm sure this was 150%. Please note her pulmonary blood flow, which is cardiac output measured by the Fick principle, was relatively well preserved, kind of average value at peak exercise. We'll come back to that. And what she had in terms of her hemodynamics was this. Her right atrial pressures fail to augment normally. They normally go up to about 10 millimeters of mercury, and here they're kind of skimming the trees here. This is what we've come to call preload failure, and I'll get into this a bit. Additionally, and I'll come back to this in a few slides, she had impaired systemic oxygen extraction, in this case denoted by the mixed venous oxygen saturation. Here it is at rest, here it is at peak exercise. It should be about 25% at peak exercise. We got a skin biopsy for small fiber neuropathy, and again, I'll come back to this, and it was floridly positive. The density of the neurites in the epidermis were way low in the first centile compared to normative controls. So she had small fiber neuropathy, preload failure, and impaired oxygen extraction at peak exercise, which I'll come back to. All right, we got into this business about 6-7 years ago when we increasingly recognized that we were being referred patients with exertional intolerance of all kinds, we focused on dyspnea, but there was more to it than that, as we found out. And they were not defined with the invasive cardiopulmonary exercise test with intrinsic heart or lung disease. So we systematically looked at this. What we did was examined our invasive cardiopulmonary exercise test database of about 600 patients at the time, and ruled out every patient who had a limit due to intrinsic heart or lung disease. We identified individuals who were impaired, denoted by a VO2 max or peak less than 80% of predicted, and we had a cadre of normals we were able to compare to. What differentiated these impaired patients without intrinsic heart or lung disease from the normals were low filling pressures. Here's the right atrial pressure, and here's a surrogate for the left atrial pressure, the pulmonary capillary wedge pressure. Two other things of note here. This is all upright exercise. If there are folks in the audience who are doing any invasive hemodynamics supine on the cath lab table, you miss this signal. So gravity is the enemy here. Right atrial pressures are lower, and especially at peak exercise, a signal not so robust at rest. Same on the left side. And if we regress some time-honored outputs from the invasive cardiopulmonary exercise test, the VO2 peak and the cardiac output peak against filling pressures, you can see the lower the filling pressures on both sides of the heart, the lower the VO2 peak, and the reason seemed to be cardiac output. So we call this preload failure. We think it's pooling of the blood in the periphery, inability of in large part, the autonomic nervous system to squeeze down big veins and prime the pump, as it were, preload failure. What we determined in retrospect was many of these patients had POTS. Many of these patients had met IOM criteria at the time for ME-CFS. We did an interventional cohort where we tanked patients up. We identified the low filling pressures at rest, and they did the initial invasive cardiopulmonary exercise test. We then gave them normal saline boluses to try to get the right atrial pressure up at rest, and then had them cycle a second time about 45 minutes later. You can see that everything is better for almost everyone. VO2 peak is higher, cardiac output is higher, stroke volume is higher, and the reason these things happen are the filling pressures are higher for all except for one individual. So that's a little bit of preload failure. We took a little more refined look at some of these invasive hemodynamics during exercise and any potential linkage to this small fiber neuropathy 2 summers ago. With the help of Philip Joseph, who's now at Yale, we did a little deeper dive into the pathophysiology of this disease. So these are all patients with exertional intolerance compatible with ME-CFS, not long COVID yet. And we did something that's been done with the upright tilt table test, and that's divided our patient population into tertiles of blood flow, that's cardiac output, and in our world, this is pulmonary blood flow, and versus the VO2 slope. It's known that this slope of cardiac output versus VO2 during incremental cycling is normally about 5 or 6 ml per ml. And by definition, there was this middle group. And back here on the blue is kind of the classic preload failure. These are low cardiac outputs at peak exercise. They have the preload failure. Here's the right atrial pressure at peak exercise. That was kind of what we had already defined. But this group was the group in red was the one of interest and kind of something that we stumbled upon. So this is a high flow group. Their slope is higher. Their peak exercise cardiac output is higher. And what decreases their VO2 peak is impaired systemic oxygen extraction. So this combination of things, a lot of pulmonary blood flow, but a low VO2 peak, and the low VO2 peak due to impaired systemic oxygen extraction is a hallmark of left to right shunting. Cardiologists have taught us this forever. If there's an atrial septal defect, which we know none of our patients had, this is what one sees. A lot of pulmonary blood flow and ineffective systemic blood flow the oxygenated red cell is not getting to the muscle mitochondrion properly. There's no ability to take up and utilize oxygen. So extraction of oxygen is abnormal. We believe this is peripheral left to right shunting. We asked additionally, what was the relationship of this impaired oxygen extraction to the prevalence of small fiber neuropathy defined by this epidermal skin biopsy? And the answer was a similar prevalence to that described in POTS and fibromyalgia, and perhaps in Gulf War illness. That's in about 45%. That's with a single epidermal skin biopsy. We subsequently done deeper biopsies in an effort to get sweat glands, and that number is up around 67%. So a huge number of patients with small fiber neuropathy and these vascular abnormalities. Just a quick, this is unpublished. It's going to be presented in a couple of weeks in San Diego at our lung meeting, American Thoracic Society. We found some sex differences, not in peak exercise VO2. These are all ME patients, not in preload failure, but rather a tick upward in the female sex of cardiac output, pulmonary blood flow versus VO2. This high flow phenotype is more prevalent in women. Don't know the reason for that, don't know the role of sex hormones, but it's something we have to learn more about going forward and potentially treat. I'm going to shift gears now and tell you a little bit based on a small study of long COVID using the same approach of invasive cardiopulmonary exercise testing and some of our findings there. And this will look frighteningly familiar. I think you heard Nancy say that a lot of commonalities between ME/CFS and long COVID, and perhaps Gulf War illness, and I would agree wholeheartedly with that comment. So these were 10 patients more than 6 months out from their acute COVID compared to 10 normal controls. A couple of points here. One is the VO2 peak is modestly depressed. So remember that, please, in these patients. If you see 70 or even 80 or 90%, don't write them off. There may be abnormalities that we can find. The peak cardiac output, again, pulmonary blood flow is the same as normal. And what differentiates patients from controls is the ability of the periphery to take up and use oxygen. It's about half normal. And here's the right atrial pressure. I think this is a type 2 error given the small numbers. Preload failure is there as well. So here's where they land in our algorithm. These two buckets, both long COVID and ME/CFS, have preload failure. This is ubiquitous, and this is a subset of patients, and predominantly women, we believe, impaired oxygen extraction. I'll give you this super quickly. This is a collaborator of ours, Frank Rice from Albany, who does hypothenar biopsies from the palm of the hand, where he gets the epidermis and blood vessels in the dermis. What he's demonstrated with special staining is that we all have potential AVMs connecting the artery with a vein, and they can open and close as a result of neural regulation. And what's surrounding this potential shunt in the skin is actually small fiber nerves. And in small fiber neuropathy, although there's a decreased density in the skin, ones that remain are dysfunctional and overactive, like fibromyalgia. That's the pain end of things. So one potential hypothesis is that dysautonomia or autonomic nervous system may result in left to right shunting. So this leads me to a tentative conclusion that in both of these diseases that are manifested by preload failure and peripheral left-to-right shunting, and whose prevalence of small fiber neuropathy may be as high as 2/3, is that we have prevalence of neurovascular dysregulation. All right, let me tell you just a little bit about shortness of breath in these disorders. So remember in that Oldham paper, we initially looked at dyspnea, at other forms of exertional intolerance symptoms as well, but dyspnea was a hallmark of these folks with what turned out to be ME/CFS. Others have recognized this. This is the Cleveland Clinic with a statement that dyspnea can result or be associated with low preload states. And a little bit on long COVID. This is a group from Mass General who's followed collegiate athletes who had acute COVID out longitudinally with a variety of questionnaires and some limited physiologic workup. And what I wanted to show you is that one of the major symptoms in long COVID in these ex-college athletes is dyspnea. So what's the pathogenesis of shortness of breath in long COVID, and presumably a subset of ME as well? So what we find is something interesting, and it's all about hyperventilation. You can measure non-invasively a VE, VCO2 slope, minute ventilation, CO2 output at the mouth. It's called ventilatory efficiency or inefficiency if it's high. And in that Indy Singh paper I presented just a second ago, the abnormality of breathing control was this excess ventilation versus VCO2. Physiologically, by the alveolar ventilation equation, there are two potential reasons for a high slope. One is hyperventilation. The other is parenchymal lung disease with a lot of dead space ventilation. And to cut to the chase, it's all about hyperventilation in these patients free of heart and lung disease. The pathogenesis of hyperventilation and the associated shortness of breath during exercise is incredibly poorly understood, and it's something that we are actively investigating. Others have recognized that hyperventilation is part of this picture. I'll point out that small fiber neuropathy can be associated with long COVID. We have some hypotheses that this small fiber neuropathy may actually be related to the hyperventilation. Maybe more on that in a year from now, Nancy. So last, I wanted to tell you a little bit about treatment. And this is a little bit on commonalities if you're interested in doing that. Back to our case here. We gave this patient pyridostigmine, aka Mestinon. This is an off-label comment. This is a myasthenia gravis drug that's known to increase acetylcholine in the neural synapse. And myasthenia gravis, it's at the end plate, but it does so at other nerve connections, and I'll show you a diagram in a second. We put her on a traditional dose that we use at the Brigham, 60 milligrams POTID 3 times a day. That's a POTS type approach here. She was followed up about a year later. The program director who fired her needed another non-invasive CPET to document she was better. And on this monotherapy, her VO2 peak had improved from 73% to 100%. She then ran the Boston Marathon, and she's now an anesthesia attending at Boulder. She lived happily ever after. We've had a lot of success with Mestinon and one other drug I'll give you in a second. We did an invasive randomized placebo-controlled study of pyridostigmine in ME/CFS using the invasive CPET. These patients had their initial exercise test, then they received a single tablet of 60 milligrams of Mestinon and then pedaled again 45 minutes later. Mestinon is thought in this business, in POTS and perhaps neurovascular dysfunction, to operate in the sympathetic ganglion where it increases acetylcholine. And then remember, there is an adrenergic or sympathetic outflow to the blood vessels. So did it work in our study? Well, it did. The effect size was small, but it was a single dose and it was acute. VO2 peak went up if they got drug. It actually went down if they did not 45 minutes later. The reason the VO2 peak went up was cardiac output. And the reason the cardiac output went up, we think, was improved venoconstriction. So we would conclude based on these data, we've used a neuroactive drug, pyridostigmine. We've improved VO2 peak. We begin to conclude, based on all these data, small fiber neuropathy prevalence, and the fact that pyridostigmine helps us, that we have neurovascular dysregulation at play. We are going to pursue this with a study that's funded by the Open Medicine Foundation called the LIFT study. We just have achieved human studies approval for this. We're going to look at 40 patients in each of these 4 arms. It's Mestinon plus another drug, which is thought to be anti-inflammatory, low-dose naltrexone, versus these 2 drugs in isolation versus placebo, all over about 3 months. We have a variety of outcome measures, including questionnaires and a bunch of omics listed down below. They're going to wear Garmin watches throughout the 3-month trial, and they're going to do a non-invasive so-called shape test before and after the intervention. This is essentially a non-invasive steady state cardiopulmonary exercise test. So that's what I wanted to end with. Thank you for your attention. I get too many people to thank, then I can go over, but I do thank you for your attention. I appreciate it.